and health professions, and he's the Robert G. Frank Endowed Professor of Clinical and Health Psychology. Actually, I didn't learn until this morning that Mike and I came here to the University of Florida, or started as faculty members at the same time back in 1990. Mike was appointed dean of that college in 2009 after serving as an interim dean for a period, and he's actually seen his college grow to more than 2,500 students, and it has a whole variety of different aspects to it. It's very pragmatic in terms of the college of what Mike does. His focus over the years has been on the notions of disease prevention and how you can alter it in terms of diet and physical activity. He has more than 200 publications and has been the recipient of many tens of millions of dollars of research funding. And he has received a number of awards for his efforts. And sadly, well, maybe not sadly, we're always happy when people move on. But, Mike, if you can also give us an update on your role here at the university. But again, thank you for your contributions to the field, and we appreciate you joining us today. Thank you.
Okay, thank you, Mark. I'm glad to be here. I have to say that I think one of the very first talks that I gave as a faculty member back in 1990 was to the diabetes group, and I think Dr. Rosenblum was the person who invited me to come over and talk to the group. So here I am. I guess it's, what is it, 30-something years later, and continuing to do the same thing. Anyway, what I would like to do is talk with you today about successes and failures in the behavioral management of obesity, in particular in relation to implications for the treatment of prediabetes. First, in terms of disclosures, and other than some grants from the National Institutes of Health over the last few years, I don't have any other conflicts to declare. In terms of objectives, I'll talk a little bit about the prevalence and seriousness of obesity and prediabetes in the US. Focus for a while on background related to behavioral management of obesity, talk a little bit about theory and research and the practice of it. Then what I'll do is highlight some of the successes that we've had, particularly with related to initial weight changes and the impact that those changes have on managing disease and preventing disease. But then also talk about probably the two big challenges in this area, which is how do you maintain the treatment effects, or the maintenance problem, and the other is how do you make them available, the access problem or the dissemination problem. And then I'll end with a few ideas for future directions. So most of you have probably seen this chart from the CDC. If you define obesity in terms of a BMI of 30 or greater, over the last half century or so, we've almost tripled the prevalence of obesity among adults in the US. And the big part of the reason why we're concerned about the large numbers of people who fall into this category are these curves here, which show the relation of body mass index to mortality. So in the above panel, the top panel, you have women, and in the lower panel, you have men. And you see that the relationship between BMI and mortality is J-shaped. And if we take a look first at this orange curve here, you see that if you have a very low BMI, you're at increased risk of mortality, the low BMI being less than 18.5. And then in the 20s and middle 20s for the BMI, you see the lowest point in terms of excess mortality. Then it starts to come up and it gradually increases. Now this includes all subjects. If we take out people who smoke, the curve changes slightly. The reason we would take out smokers is smokers tend to have lower BMIs, but they also tend to die earlier. And if you take them out, you see an even stronger relationship between BMI and excess mortality, both for women and then also for men. So not surprisingly then, what we end up seeing in practical terms is that obesity can shorten life by 1 to 10 years. And that's probably happens through its association with 5 of the 10 leading causes of death in the US. And so it's linked to heart disease, to stroke, diabetes, of course, certain cancers, and to pulmonary diseases. And the estimates vary, but most estimates suggest that there are more than 300,000 deaths per year that could be attributed to obesity. Now, if we look at the association between BMI and the risk for type 2 diabetes, we see that there's a curve for both men and for women, such that by the time you get to a BMI of 35, you've got more than a 40% increase in risk among men and an over 93% increase among women. And if we follow this curve, if it had gone out to 40, you really see the exponential nature of this, because the increased risk almost goes to tenfold when you start to get to the very severe cases of obesity. So now we'll talk a little bit about prediabetes. Prediabetes is defined typically as blood sugar levels that are higher than normal, but not high enough to be diagnosed as type 2 diabetes. And so with those cut points typically are hemoglobin A1C of 5.7 to 6.4, or fasting blood glucose of 100 to 125. Now, using those cut points, if you say, if somebody has one or the other of those, you find that there are 88 million Americans, and that almost 35% of the population has either an elevated A1C or an elevated fasting blood glucose. If you say somebody needs to have both an elevated A1C and an elevated fasting blood glucose, it brings the number down to 28 million people, but still 11% of the population. And of these people, of the 88 million, physicians have told the individuals, only 15% of the cases report that they've been told by their healthcare provider that they're in this category of having prediabetes and of being at increased risk. And so the consequences of prediabetes is obviously that there's increased risk for type 2 diabetes. It's thought that the incidence among people with prediabetes of being diagnosed with diabetes is about 10%. So in a given year, 10% of the people with prediabetes convert over, their blood levels go high enough that they're then able to be diagnosed as having type 2 diabetes, which also then places them at increased risk for heart disease and stroke. The consequences of higher than normal blood sugar levels have been known for a long time. And we'll talk a little bit about the different treatment options, which tend to focus in many cases on the treatment of obesity because of the close association between obesity and the elevated levels of blood sugar. When we talk about professional treatment options for obesity, essentially comes down to 3 options. The first is behavioral or lifestyle treatment, which is going to be the focus of this talk. But then there's also pharmacological treatment and then bariatric surgery. If we talk about lifestyle and behavioral treatment, I want to point out a few distinctions in terminology that sometimes can be a little bit confusing. First of all, when we talk about lifestyle treatment, essentially what that means is that we're going to be talking about the use of diet and exercise as the means of achieving weight loss. When we talk about behavioral treatment, we're going to be talking about applying principles from behavioral psychology to help achieve those changes in diet and physical activity. And the reason we want to achieve changes in diet and physical activity is so that we can alter the energy balance, create a negative energy balance, and thereby produce weight loss. So one of the things that gets confusing, the literature also uses this term a lot, intensive lifestyle treatment. And what this refers to, and you'll see this term used by the Preventative Services Task Force and other groups is a combination of lifestyle treatment, diet, and physical activity, plus a moderate or greater dose of behavioral treatment that's used to achieve the changes in diet and physical activity. A little bit about the behavioral theory behind this, and I'll use myself as an example here in terms of one of my goals each day is to get 1,000 steps of walking. And I use my iPhone, and it has an application on it which tracks steps. And so I have, from a behavioral self-regulation model, I've set a goal for myself, 10,000 steps. And then what I need to do in order to achieve that goal, one of the important things to do is to track my progress toward that. So in terms of self-monitoring. Now, in the old days, we would typically write, we might have a pedometer that we wore on our belt and could track the steps and jot it down each day. Now it's all done electronically for us. So today, let me see how I'm doing. Today, let's see, I'm not doing particularly well today. At this point in time, I've got 5,383 steps. And it's unlikely that I'll make it to 10,000 steps today just by walking to my car after work and driving home. You know, if I walk to my car, that'll get me another 700 steps. That'll put me over 6,000 steps. And then when I walk the dog tonight when I get home and do a few other things, that'll get me another 1,000 steps. But I'm going to be about 3,000 steps short. So one of the important things that the self-monitoring does is provides me with information that I can use then to evaluate my progress. And that's the next step. The self-monitoring leads me to evaluate. And I'm evaluating my progress here as being subpar. And so if I were to achieve those 10,000 steps, one of the important things I would do is if I were closer to it, I'd reinforce myself and say, great job, I'm making progress towards my goals. But I'm in this other category right now where I'm not achieving the goal, so I need to do some problem solving. And so one of the things that we do in behavioral psychology is we work with individuals, set a goal, have a structured program of self-monitoring, whether it's writing it down, the number of calories that they consume, or using an app. And these days, most people use apps to show them how they're doing. And then they can evaluate themselves and reinforce themselves if they're doing well. But more importantly, cycle into problem solving if they're not doing well. So here's a model that we use, and we use a structured 5-step model. The first step is, how do we talk to ourselves about not doing well? And so part of this is to normalize having problems. It's going to be expected that we're going to run into difficulties in making changes in diet and physical activity, but it's also possible to be successful with this. And so it's a motivational component to say, I expect that there are going to be problems from time to time, but I also know that there are going to be ways of dealing with problems effectively. So what's the specific problem facing me and what's the goal? So in this particular case, I need to figure out a way to get 3,000 more steps today before the end of the day if I hope to get to 10,000. And the problem for me is if I get in my car and go home, I'm not going to be there. So my goal is to figure out a way to get to 10,000 steps. In trying to figure out that, one of the things that I want to do is generate a lot of different possibilities, because we say quantity breeds quality. The greater range of options that I consider, the greater the chances I'm going to come up with a good solution. So one of the things I could do, for example, is I could cancel some of my appointments this afternoon and go out for a walk. That could work. I could, I know that 3,000 steps, people generally walk at about 100 steps a minute. So 10 minutes gets you about 1,000 steps. It'd take about 30 minutes of walking then to get 3,000 steps. So I could say, well, when I get home tonight, one of the things I could do is I could go out for a 30-minute walk. That's another option. Another option is maybe before I leave work, stay an extra half hour and go for a walk on campus for 30 minutes to get that time in. Anyway, I'd want to come up with a bunch of different possible ways of getting to that extra 3,000 steps. The next step is decision making. Think about the likely short and long-term consequences of each of those steps. Now, if I've got, as I do coming up, we have a job candidate coming up. I think if I cancel the talk with the job candidate, that won't go so well. I also have to go to the colloquium or the presentation by that job candidate. Skipping out on that won't work so well. So some of the appointments I have, I'm going to have, it might work over the short run, but then I only have to reschedule those appointments, and that's going to create some difficulties down the road. I could go home and go for a walk, but knowing myself, when I get home, I'm pretty much beat at that point and want to just sit down and have dinner. So going for a walk once I get home is probably not going to work. For me, what's likely to work the best is before I get in my car to do 30 minutes of walking, because I know for me that that's most likely that I'll be able to achieve that and that I'll be successful in getting this. So the next step is I pick what I think is the best option and I try it out. And what I'll know is by the time I get to bed tonight and I check my phone and check on my activity, if I've made it to 10,000 steps, I know that I've been successful in solving this particular problem. If it didn't work out, if say at the end of the day, I just was too tired and I just went home and settled in and ended the day at 7,000 steps, I'd know for the next time around that I have to come up with a different way of handling this. So those are some of the background in terms of how this model works. What are some of the practical ways in which this is implemented? Well, first of all, you need somebody who's going to deliver the intervention. And in most cases, it's usually somebody who has a bachelor's degree or greater, and with a background, particularly either in psychology or nutrition or exercise science, and who's had specific training in how to do this. It doesn't take a Ph.D. in psychology. It also doesn't take a registered dietitian or a Ph.D. in exercise science to be able to deliver the intervention. But it does take training, more than a workshop or two, and it does take someone to monitor your progress and give you feedback in terms of how well you're doing as an interventionist. In terms of how the programs are typically delivered, the most common way in which, or the best way in which it's done, is in a closed group format, and where you have 8 to 15 people who start treatment at one time and they go through treatment together. You don't swap out new members. It's the same people who start out who stick with each other throughout the process. Generally, there's a little bit of research that shows delivering this treatment in groups tends to be more effective than delivering it individually. And part of that is the group support aspect. Session lengths tend to be 6 to 90 minutes long. The treatment goals in terms of the diet and physical activity part is usually there's a daily intake goal set between 1,200 and 1,500 calories per day. And that's part of that is determined based on the individual size. And what you want to do is set up a program that's going to help them to achieve a 1 to 2 pound per week weight loss over time. In addition to that, you want to have a physical activity component. The most common thing that's used is setting up a walking program where it's 30 minutes additional beyond whatever their baseline is. And so we would get a baseline on individuals by maybe having them use a pedometer or their phone for several days to see what their normal number of steps is. And then what we would do is gradually add more steps using the rule of thumb of 100 steps equals 1 minute. And so we'd want to increase their daily routine by 3,000 steps per day. Treatment is typically these days done in 2 phases. Some of it depends on the dose of treatment, but initial treatment would typically be 12 to 24 weekly sessions, and then there would be a maintenance program that would involve either monthly or semi-monthly sessions for another 12 months. This is the most common way in which it's delivered these days. So how effective is behavioral treatment? And one of the things that we know is that there have literally been hundreds of randomized trials that include behavioral treatment, and we know how well it works. It reliably produces 5 to 10% reductions in body weight that are followed by gradual regaining of lost weight. Changes at the 5 to 10% level typically are accompanied by beneficial improvements in disease risk factors, including blood pressure, blood glucose, and blood lipid levels. And over the past 10 years, behavioral lifestyle treatment has been endorsed as the frontline treatment for obesity by virtually all the major professional and scientific organizations, including the American Diabetes Association, the American Heart Association, the Obesity Society, and the US Preventive Services Task Force. So while we have data that shows that modest weight changes of this degree can improve risk factors, there's not a lot of data to show that these changes then and improvements in risk factors actually prevent disease or lengthen life. As people are sometimes surprised to know, there are no randomized trials that show that weight loss increases longevity, and there are very few trials that show that it actually prevents disease. However, there is what is now, a classic study, the Diabetes Prevention Program, which was reported back in 2002. And this was a multi-site randomized trial that essentially took people who had impaired glucose tolerance, is what they called it back then. Now we would call it prediabetes, and said, well, what if we treated them with either metformin or intensive lifestyle treatment? If we tried them on either of those treatment options, could we actually prevent the onset of type 2 diabetes? So the study design was very straightforward. There were a little over 3,000 people who were randomized to intensive lifestyle treatment, to metformin, or to a placebo. And the primary outcome for the study was incidence of diabetes, to take a look at how many of these people who were pre-diabetic actually developed diabetes. These are the weight changes over the first 4 years. You can see the placebo group pretty much stayed the same weight. The metformin group, though metformin was not being used as a weight loss method, but the metformin group lost a little bit of weight over that time. And the lifestyle group did pretty much as expected. There was about a 7 kilogram weight loss, which was about 7% of body weight for the participants, which was gradually regained over the course of 4 years, such that people regained about half of the lost weight during the 4-year period of time. Now, what happened in terms of the primary outcome during that time? So this is the cumulative incidence of diabetes after 4 years. And you can see the placebo group acted pretty much as was expected. It had been hypothesized that the incidence of diabetes among these folks would be about 10% per year, and it was a little bit higher than that. And you can see metformin group actually reduced the incidence of diabetes from 44 down to 31. And probably the most surprising finding was how well the lifestyle group did, with the incidence reduced down to just 18%, which was like a 58% reduction in incidence. So that was really exciting, and those data were reported back in 2002. And then those individuals in the DPP program continued to be monitored, and they continue to be followed to this day. If we take a look at what happened in terms of their weight loss, Here you see the intensive lifestyle group, and as we already saw, they started regaining weight. And over time, their weight changes were no different than the metformin group. Now, what happened in terms of incidence of diabetes? Well, one of the interesting things that happened was that the benefits of metformin and lifestyle continued to show up in terms of decreased incidence of diabetes over the course of the study. And you can see that in terms of, here's the incidence for lifestyle. So even with the regaining of lost weight, the benefits were still evident over the course of 15 years, though the difference between the metformin and lifestyle groups were virtually nil. Both groups do significantly better than the placebo group. So one of the important messages for people who undergo treatment then is that it's better to lose weight, even if you're going to regain it, than to never lose it at all. Because the years in which they were at the lower weight reduced the incidence of diabetes and forestalled the onset of diabetes, and the impact of that continues to be seen over the course of time. And indeed, there's a report just this past summer from the ADA showing that new data from the diabetes prevention program showed that over 22 years, the impact was still observed, with a 25% reduction compared to the original placebo group for the intensive lifestyle group, and an 18% reduction for the metformin group. Okay, so let's go back now to dealing with behavioral management of obesity. The good news part is we are able to produce these initial treatment effects. The bad news part is you see this check mark pattern is apparent in almost every study of weight loss outcomes that uses behavioral treatment. In this particular study that's shown here, you see that the participants lost a little over 8 kilograms, and then they were followed for 30 months. Within 6 months, they had regained a quarter of their weight. Within 12 months, they had regained half of their weight. And then it kind of levels off at that. And they maintained about 40% of their weight loss at that point. So why is it so difficult to maintain lost weight? And I believe it's a combination of factors, and I'll just point out a few of those. First of all, there are environmental factors. We release people back to their environment. They might come in and might be in a weight loss group for an hour, but for the rest of the week, the other 167 hours, they're constantly exposed to low cost, very tasty, energy dense foods. In addition, so that's on the intake side. On the activity side, there are lots of barriers to exercise. The most common one that people point out is they just can't find the time to do it. Things come up that get in the way. As a result of the constant exposure to foods and the difficulty in sustaining exercise, individuals are primed for a slip or a lapse, particularly once the group format stops and they're on their own. So environmental factors play a big piece in this. Also, there are biological factors that play a role. One of them is that as a result of taking in lower amounts of energy over time, the body reacts with adaptive thermogenesis, which is essentially metabolic rate slows down. And so as a consequence of that, it becomes easier to regain weight if you take in additional calories. In addition, the loss of body fat probably triggers hormonal changes that are important in regulating both appetite and satiety. And these are the changes in leptin and ghrelin. So as a result of that, we have people very easily then primed. It becomes easier to regain weight once you've lost weight than if you had never lost weight at all. So this sets people up from both an environmental and a biological perspective for difficulty in maintaining loss. Then there are also psychological factors. A big part of it is unrealistic expectations. Some of my favorite studies there's a study that came out of the University of Pennsylvania, probably about 15 years ago, where they asked people who were starting a behavioral weight loss program, how much weight they expected to lose. And on average, they said that they expected to lose 30% of their body weight. They were then told that the average person could expect to lose 5 to 10% of their body weight, and said, now that you know what the average is, how much weight do you expect to lose? And they said, okay, on average, they changed their mind. They didn't expect to lose 30% of their body weight. They expected to lose 25% of their body weight. So almost everyone going into treatment expects to lose far more weight than they actually do. The second thing that's unrealistic for many folks is that they have an unrealistic expectation about the impact of weight loss. If you ask people why they want to lose weight, as you might guess, the number one reason is related to appearance. And they think that the improvements in appearance will bring about other kinds of things in their lives, in terms of improve their social lives, improve their lives at work. And they expect lots of benefits to accrue from losing weight, in addition to looking better and also feeling healthier and being healthier. Finally, expectations about the length of effort that it takes to lose weight and keep it off is unrealistic. Most people come in wanting to lose a lot of weight in a short period of time. You know, they love it when they see signs for around town that say lose 30 pounds in 30 days, ask me or call this number. Most people want the length of treatment to be short, and they want the amount of weight loss to be large. And the truth of the matter is that it doesn't work that way. There's also a lack of reinforcement for maintenance. There's lots of reinforcement that people get for losing weight, but for staying the same weight after you've lost weight, you don't get that much attention. Also, treatments focus largely on how to lose weight. They don't focus on maintenance skills, or how do you sustain weight? How do you sustain progress in the face of these environmental factors that are set up against you and the biology that's set up to undermine you? So as a result, when you get to the maintenance phase, there's a kind of an unfavorable cost benefit. People are working pretty darn hard to lose weight. The rate of weight loss slows down, and they're not getting the benefits in terms of their expected amounts of weight loss or the impact in terms of their appearance, and they're disappointed at how long it's taking. And so what can happen is this can set them up to get discouraged and abandon the entire weight loss effort. Some other important differences: when we're counseling people for weight loss, we know what the caloric intake is that is required to lose weight. It works out pretty well that 3,500 calorie deficit leads to a pound loss. So you can tell people, if you cut your intake by about 500 calories a day, you're going to lose on average about a pound. We don't know what to tell people in terms of how many calories they need to sustain weight loss. And what we do there is we just do it by trial and error. During the initial phase of treatment, we teach weight loss techniques explicitly. When we get to maintenance, we don't have specific techniques to tell people to do other than keep doing what you've already been doing. When people start off in weight loss programs, they're incredibly enthusiastic and excited about getting going on it. When they get to the maintenance phase, they're kind of burned out at that point in time. You can imagine they've been going for weekly sessions for 3 to 6 months, and now you tell them you've got to continue with this. They kind of are disappointed to hear that. Initially, you get high attendance and good adherence to keeping self-monitoring records. By the time you get to the maintenance phase, attendance drifts off. To give you an idea, we typically, during the initial phases, get attendance rates in the neighborhood of 85% over 6 months. When we get to the maintenance phase, the attendance drops to less than 50%. While there's a good cost-benefit ratio during initial treatment, the perception here is a poor cost-benefit during the maintenance phase. As I mentioned before, people come in with high expectations, but by the time they get to the maintenance phase, those expectations have decreased significantly. They now know they're not going to lose 25 or 30% of their body weight just using behavioral methods. And that can be discouraging for people. They were expecting to look like somebody on the cover of GQ or Vogue in terms of the secondary benefits, in terms of appearance. And they now know that while they may have dropped a size or two in dress size or belt size in their pants, they're not going to be on the cover of Vogue or GQ. While initial weight loss comes pretty easily, it becomes really hard. You hit kind of an asymptote by the time you get to the maintenance phase. And as I said earlier, weight loss is rewarding. Lack of further weight loss is demoralizing. People come up to you and after you first lose weight and say, you look great, you lost weight. People don't come up to you and say, you look great, you stayed the same weight. We set up our program so there's a high level of clinical contact during the initial phase. But what do we do when we get people to the maintenance phase? Either there's little or no contact that follows that. So what does this all mean in terms of treatment implications? Well, some researchers take a look at this and say, hey, there's an overwhelming influence of biology and environment that individuals just can't overcome. And so what we really need to do is focus our efforts on finding an effective long-term pharmacological agent. Other people look at it and say, we're putting too much of the emphasis on skills training and expecting people to learn behavioral self-management skills to maintain diet and exercise. What we need to be thinking about is how to change the environment to support their efforts. Environmental changes could range from, one of the things that's pretty neat is a lot of restaurants now, you go in, you can see the actual calorie amounts of the different food choices. And so that helps you in terms of making choices. Or environmental changes could be changes to the built environment, more walking trails where it makes it easier, say, to walk at work rather than having to go and drive someplace to find a place to exercise. Then I think another implication is that we really have failed to provide a treatment model that's suitable for a chronic problem. And so I've argued this for a very long time, is that we really need to treat obesity as a chronic condition. And if it is a chronic condition, then we're going to need to think in terms of a continuous care, problem-solving approach to treatment. Okay, so the maintenance problem is one big problem. A second big problem is the dissemination problem or access to treatment. Right now, pretty much the only places where you can get intensive lifestyle treatment or behavioral treatment tend to be in academic medical centers. There's very little dissemination out to the communities, particularly to low resource communities. But given the success of the DPP program, the National Diabetes Prevention Program was started by the CDC with the goal of making it easier for people with prediabetes to participate in affordable, high-quality lifestyle change programs so as to decrease their risk of type 2 diabetes and improve their health. And the way this is done is that organizations can partner with the CDC and set up a national DPP site. And it takes a fair amount, though. You have to have individuals who go through the training and get certified. It's usually a minimum of 2 days of training that's by an official national DPP program, either held at the CDC or at one of the partner institutions across the country. And that the site also has to set up standards for monitoring the participants and documenting successful outcomes in those participants before the site can have full certification as a national DPP site. So the goal here was to make it easier. And so one of the things my students and I did a couple of years ago is to check out how well this is working, particularly for people who live in rural communities. And we looked at the expansion of the DPP across all sites in the country, and then we categorized the sites as to whether they were present in rural versus urban areas. And we looked at hospitals and medical centers that had DPP programs, health departments, wellness centers, YMCAs, and then we rolled them all up into this total. And what we found was that if you lived in almost 50% of urban areas, had access to NDPP programs. But if you took a look at rural communities, it was less than 15% had access to these programs. So one of the ironies of the development of the national DPP program is that it did indeed expand access, but it expanded differentially, such that there was much more access in urban areas than there were in rural communities. And part of that is, a big part of that is the resources required. To get NDPP designation, you need to have at least 2 personnel who are devoted to it, somebody to do the delivery of the intervention, but you also need somebody to track the outcomes of the participants and provide the data to the CDC. So what I'm going to do now is I'm going to quickly tell you about a couple of studies that we've done that have addressed both of these problems, both the maintenance problem and also the dissemination problem. The earliest study that we did was published back in 2008, and it was called the TOUR study, or Treatment of Obesity in Underserved Rural Settings. And we wanted to do 2 things. We wanted to address the dissemination problem, and we also wanted to address the maintenance problem. In terms of dissemination, we looked at an alternative infrastructure that could work in rural communities, and that's the Cooperative Extension Service. And Cooperative Extension has offices in almost every county in the country. It has offices in more than 3,000 counties nationwide. So it's out there in rural communities in particular, and it's well respected. And so we said, could we take personnel from the Cooperative Extension offices and train them how to deliver intensive lifestyle treatment? The second thing is that we wanted to look at different maintenance programs. And in particular, we wanted to see if we could develop maintenance programs that would be less expensive than face-to-face treatment. And we focused on telephone counseling. And we wanted to see the long-term effects of telephone counseling on both body weight and heart disease risk factors, including HbA1c. And so what we did was we set up an intensive lifestyle intervention program. Everybody got an initial 6 months of weekly sessions that were delivered face-to-face. And then following that, they were randomized to 12 months of either continuing face-to-face sessions twice per month, or telephone sessions twice per month, or newsletters that were delivered with information about maintaining weight loss that were delivered every other week. Here's the initial reductions in body weight. We were very, very pleased at this. These are percent changes in body weight. And you can see this is before randomization. All of the groups lost over 9 or just about 9% of their body weight. And you can see that percent body weight was even better than what was achieved in the original DPP. So one of the things that this showed us is that we could train individuals at the Cooperative Extension offices to deliver the program effectively, that residents from those communities who signed up for the program would achieve weight losses on par with what was achieved in the initial DPP. But then the experimental part of this is what happened over the next year. And you can see the weight changes here over the initial phase. And then here's the weight changes 12 months after extended care. And both the telephone group and the face-to-face programs did significantly better than the control group. And these results are illustrated in this slide. So the group that was the control group that got the mailings, they maintained 67%, 2/3 of their initial weight, whereas both the phone and face-to-face conditions, which received extended care, maintained 90% of their initial weight losses. So both of these programs seem to be effective compared to the control group. We also looked at what happened in terms of HbA1c. One of the things you could see is that the mean A1C levels for this population was in the pre-diabetes range. It was a little bit less than 6, so it was 5.94. And that was reduced after the initial treatment phase to 5.7. And it went up a tad at long-term follow-up, but still was significantly lower than where it had been at pre-treatment. And the other issue that we were interested in was reducing cost, because we knew that if this were going to be disseminated, it had to be lower cost. The cheapest program, obviously, to put on was the male program, which was about $116 per participant. Our telephone program cost us $192 per participant, which was still significantly lower than what it cost to put on the face-to-face program. It was less than half of that. The face-to-face program cost $400 per participant to put on. So one of the things that this told us is that we could deliver extended care effectively through telephone counseling rather than face-to-face counseling. This has a major advantage in rural communities also because of the distances that people have to drive to get to a county center for treatment. And so if the treatment could be done by phone, that would be a major improvement. So we took that idea and we said, well, what if we did the telehealth program, not by individual telephone counseling, but what if we did it in a group telephone counseling using a group conference call format? And these are results from a study that we published last summer that compared individual telephone follow-up with group telephone follow-up compared to an education control. And in this case, rather than sending out mailings, we provided the materials to the educational control group via email. So all the groups prior to randomization achieved the same amount of weight loss, about 8.5% weight loss. And then you can see what happened. Here's the control group, stayed flat for a while and then started regaining weight. And then here are the other two groups. Now, in terms of statistical significance, at 22 months out, only the individual telephone counseling group did significantly better than the educational control group. The group format didn't work quite as well. It was not statistically different. It approached it, but was not statistically different. Another marker of success of the individual counseling telehealth program was the percentage of people who had almost 2 years after the start of treatment had maintained weight losses of 10%. And you can see that 32%, almost a third of the sample, successfully maintained a 10% reduction at almost a 2-year follow-up compared to less than 20% for the control group. So the bottom line there is we were able to replicate the effects of the individual telephone counseling for extended care program, but we were not able to show the same degree of effectiveness for group telephone counseling. Another issue that we've looked at has been the dose of treatment because of the expense associated with high dose treatment. And so we did a study that was published in 2014 where we compared high dose treatment then with a moderate dose treatment. And what we did was we cut the dose both of initial treatment and of long-term treatment by a third. We went from 24 initial sessions down to 16 and 24 extended care sessions down to 16. And then we cut it further. We cut it by 2/3. And the reason we cut it by 2/3 is low dose treatment is the most common dose treatment that you'll find out in the real world. And we wanted to see how well these different doses of treatment compare. And then we also wanted to look at, remember the early distinction I made between lifestyle and behavioral treatment? Well, what if you just did lifestyle counseling without the behavioral component in it, without use of the behavioral strategies like goal setting, like self-monitoring? Would these folks do as well? Does adding the behavioral treatment benefit people? So here are the initial results. Here's the educational program that had diet and exercise prescriptions, but no behavior modification techniques, no self-monitoring, no goal setting. These folks did pretty well. They lost 4 kilograms over 6 months. When we added to that the same dose of treatment, but we added in the behavioral techniques, you can see it increased the amount of weight loss to 7 kilograms. And that's a significant increase to go from 4 to 7. Then when we went from low dose to moderate dose, we got a significant additional weight loss of 2 more kilograms. However, when we went from moderate to high dose, we only increased the additional loss by 1.5 kilograms, and that was not statistically different. So the moderate and high groups produced about essentially the same amount of weight loss. Then we looked at how these folks did over the course of 2 years. And over the course of the 2 years, the 2 low dose treatments were about equivalent. And the advantage of adding the behavioral techniques was not seen at this point in time. Probably is too sparse an amount of additional care that was provided over the course of 18 months. Similarly, these groups were not different. The moderate and high were not different at 6 months, and they converge also at 24 months. Both of these groups did significantly better than both of the low dose groups. So what that suggested to us is that we could reduce the cost of treatment by using a moderate dose compared to low dose treatment and still get the long-term benefits. This shows that in terms of percentages of people achieving 5% losses at 24 months, both the moderate and high dose did almost identical, and both of them were significantly better in terms of numbers of people who percentage of people who participated who benefited with a 5% loss. There is one caveat though. When we looked at the impact on HbA1c, we found that it took the higher dose, however, to produce significant changes. Whoops. I meant to go backwards there. To produce significant changes in A1C or fasting glucose levels. So while the impact for weight may be the same in terms of doing moderate versus high doses, you do get a better impact on A1C and fasting glucose if you use a high dose treatment. So what does this all mean? Well, I think in terms of the successes of behavioral treatment, we see that we can produce reliable body weight reductions of 5 to 10%. We can see that these reductions are associated with significant and reliable decreases in cardiovascular disease risk factors, including A1C, and that can lead to the prevention or at least the forestalling of the onset of type 2 diabetes. The failures are clear. We have a lot more work to do on the long-term maintenance of weight loss. We have a lot more work to do in terms of the accessibility to behavioral treatment, particularly in low-resource communities. And we need to develop more effective policies that are going to support dissemination and implementation, particularly into low-resource communities like rural areas. We have made some progress in addressing these failures. I think we're showing pretty clearly now that if you have a continuous care model of treatment, you're going to get better long-term outcomes. You won't be able to sustain all of the weight loss so far, but you'll get better maintenance than if you don't provide extended care. In terms of addressing the limited access to care, I think there are two alternatives that look particularly promising. One is to look at low-cost alternative technologies, such as telehealth, and particularly we've shown with the use of telephone counseling can be an alternative to face-to-face counseling. And we think that it's important to look at alternative infrastructures, such as we've shown with cooperative extension in rural communities. And lastly, I think we need to take a look at effective policies that are going to support proactive dissemination and implementation, and expanding the NDPP, particularly in ways that are specifically targeted to low resource areas. And we also need to look at CMS coverage to make it easier to get obesity management covered in non-medical settings, which is a real difficulty right now. There are a lot of people I need to acknowledge who participated in this work. Here's a list of my collaborators and colleagues, and I'll stop there and say thank you and be happy to answer any questions that might come up.
Well, thanks, Michael, for that amazing presentation. I want to let others ask questions, but one of those points you had right at the very end about telemedicine, I'm just wondering if trying to look at the benefits of COVID, which I know is a challenge here in terms of how could COVID have benefit everything, but at least in the type 1 community, A1Cs, well, there's been a number of studies to say that there's been benefits in terms of care over the last year in COVID. What types of things do you think might be benefits in what you do in terms of COVID?
Yeah.
Has increased, willingness to participate, telehealth, what?
Yeah, Mark, those are a great point. So this is our telehealth study here, where we had both the individual and group. Now, what we didn't have here, and this study was done, the data were collected like 3 or 4 years ago, even though it was published, last summer. It takes several years to do it. So at the start of the study, we had no notion of using Zoom, for example. And also we thought a little bit about it, but the problem was going to be in terms of broadband in rural communities. But that situation has improved dramatically now. And I think we have a current study in progress where, because of COVID last March, we had to convert all of our face-to-face sessions to Zoom sessions. And we got really good acceptability and good results from that so far. So I think that's an advantage. I think going forward, we're going to be able to do lots of this treatment via Zoom with equivalent effectiveness as we see in face-to-face treatment. And I think that's going to help us with the whole access and dissemination problem.
All right, great. Others have questions. Or should say, do. Yeah. I see there's a chat by Eve. Can you, Mike, can you pull up the chat?
Oh, sorry. Let me get it.
Oh, keto diet. What's your thoughts on keto diet? Yeah.
Okay. There's lots and lots of research out there that essentially says the issue for any kind of diet is we need to see what happens long-term. And so there are lots of studies, meta-analyses, essentially come to the same conclusion. There may be some advantages short-term in terms of high protein diets. Long-term, there don't seem to be significant advantages in terms of adherence, and that the recommendations tend to be to tell people, figure out what approach you can stick with over the long run and use that. So that's probably the best advice that I can give right now.
Okay, great. All right. Anybody else want to chime in?
Mike, I have a question. We deal with kids in a certain community, and most of them are the lower end of the socioeconomic scale. How do you get someone? So some of the kids that we started with 8 years ago are now 18 and 19 years old, but they're still in that same cycle of they're stuck at home and they don't have control over what they eat or what they're fed. How do you make a change there?
Yeah, so I could tell you in the early days, in the psychology clinic, as a psychologist, I used to do a lot of the assessments for patients for bariatric surgery. And one of the interesting things would be when kids would be brought to us for bariatric surgery, because you can imagine they had to be quite obese to be considered. But oftentimes the parents wanted to drop the kids off and say, here, fix them. And we'd say, no, wait a second, you need to be involved in treatment. And treatment doesn't simply work by what the surgeon does. When these kids go home to their environment, that environment needs to be changed. It's going to need the foods that are going to support the success of the surgery. But even before we get to that point, let's do a test run and see if you're willing to change the foods in the home ahead of time. Because if we don't have success ahead of time, there's not going to be success afterwards. And so it's a long-winded way of saying, Joe, that it's really important to have a supportive environment at home. And if the other individuals who control the intake are not willing to work with the person who's trying to deal with their changes, the chances of success are slim. Now, what we found in our studies, typically when we recruit, we get usually 75% women to 25% men. One of the advantages of that is that often women are the folks who do the shopping and the meal preparation. And oftentimes the benefits of their participation extends to other family members, more typically to the kids than to the spouses. Oftentimes we don't want to push too much on the spouses because you can get a negative reaction if you try to change the balance in the home. So, but you're totally right. This needs to be a family process, and whoever controls the access to the foods needs to be involved.
Thank you.
Well, thank you again. We're at the top of the hour again. Thank you, Michael, again for coming on here. I appreciate it, and I think all learned a lot today. Thank you again very much. Have a great day, everybody.
Take care.
All right. Bye-bye.